Hello guys, welcome to our channel. Today we will be discussing about the pathology as part of the Mission 200 Plus Rapid Revision program. And in this subject, you all know this is one of the scoring subjects which will be integrated with the medicine and physiology and also some of the aspects of the histology, all this, right? So this is one of the important subjects for you, like likely to be 20 questions can be also seen. So before we are going into the discussion, those who are new to this channel, please do subscribe and share with your friends, and also do like the video so that it will reach the more students, guys. And also, whenever you're watching this video, after this you also watch the previous videos and also upcoming videos, and I definitely tell you this is going to help you a lot. And whoever want to have this get this annotated version of the unannotated versions, you can text me in the telegram where you can get the book. So let's start the discussion, guys. So as a part of the every subjects, we will be discussing about the one of the doctors, right? One of the scientists and one of the historians who has contributed to that particular subject. So you all must have heard his name. He is the Rudolf Virchow. So he is known for the father of pathology. He is known as a father of pathology, modern pathology, and his contributions are well known. Okay, much more and much more. So he has discovered how the cell injury has been, and also how the neoplasia, especially leukemia, chordoma, lung cancers, many other cancers he has discovered. Not just that, he also discovered the first autopsy, which is done by the system wise post the patient death. So all these contributions has been given by the Rudolf Virchow. But at the same time, Rudolf Virchow is the most controversial figure in the history because he has completely denied the fact that there is a gem theory, okay, which later on that is a true that has been based, but his contributions in the pathology was well known. But microbiology, he has always debunked that the theories, whatever the gem theories, Koch postulates, or any other, he was never accepted of. So let's start the discussion. So, so the first thing that you have to remember in the normal pathology, that is a general pathology. Okay. So the general pathology is very important, guys. Every point in the general pathology that you have to remember. So every cell in our human body, every cell can go into the stress, and that stress is considered as a reversible injury, or if it is more stress is increased, it can cause the irreversible damage also to the cell. So what is the reversible changes and what is the irreversible changes that you have to remember? So the first and foremost in the reversible injury, the cell will be having the swelling. Okay, the swell will be swelling, and also there will be presentation of the blips, and last changes which will be fatty swelling. Okay, fatty change we can also say. Next, coming to the severe or the severe distress, this can also cause the irreversible damage. What happens in the irreversible damage? You don't see the swelling, but rather than that you will be seeing that the cell membrane is disturbed. The cell membrane is disturbed and calcium deposits will be seen. These calcium deposits under the electron microscope, if you observe this, you are going to see the definition. This is commonly asked question, amorphous densities. Okay, amorphous densities on the electronic microscope you are going to see. So this is the difference between the reversible changes and the irreversible changes that you have to remember. Okay, just simple points. On the electronic microscope you will be seeing the amorphous densities, then that is likely to be irreversible damage. Next, what is the most common cause then? So the most common cause will be hypoxia, and in the hypoxia it could be due to ischemia. And what are more prone? More prone will be neurons, followed by the myocytes, and very last that will be the skeletal muscles. Skeletal muscles. So this is how the pattern of the hypoxia will be seen in this patients. Next, reversible injury has the multiple types. So these types also has been asked in the examination. So hypertrophy. What is mean by the hypertrophy, guys? If you observe here, the cell size has been increasing. Okay, so the cell size will be increasing. That is known as a hypertrophy. And most of the times, hypertrophy is related to the protein of the intake of the body. So likely to be this could be physiological. right? This is a physiological pattern that we are going to see. And what are the examples in the physiological? Example is the exercise. So if you do the more exercise, more the muscle hypertrophy will be seen. And if it is a pathological, in the pathological hypertension patients, left ventricular hypertrophy will be seen. And in the patients of the pregnancy also I will consider this as a normal only. So in the pregnancy also, if the uterus and the breast that is also going under the hypertrophy of the structures. Next, hyperplasia. In the hyperplasia, there will be size increase. Okay, but at the same time, more than the size, there is a number that will be increased. Okay, so the number is more important in the hyperplasia. It could be pathological, it could be physiological also. In the physiological, the name itself tells this is going to be the most dividing cells. What are the most dividing cells? For example, benign prostatic hyperplasia and also endometrial hyperplasia. These both are the pathological. What about the physiological? Breast development in the puberty, breast development in the puberty, and also lactation period, right? Lactation period. These two are going to be the most commonly hyperplasia. Next, atrophy. So what is happening in the atrophy? Not just as the size is decreased here, it can be decreased by the number also. So both will be decreased in the atrophy. And usually this is going to be associated with the aging and also those who are associated with the menopause due to again with the age and also due to nutritional changes. Marasmus, Kwashiorkor, all these patients will be also seen. Mostly aging, dying, deceased, all the particles, all the structures will be going under the atrophy. Next, metaplasia. Metaplasia, this is the normal cell and this is the transformation. So what is mean by the metaplasia? So the layer of the one cell layer which will be replaced by the other layer. Okay, so the replaced by the other layer, that is what the metaplasia. And what are the examples of the metaplasia? One of the most example will be the pseudo stratified columnar epithelium. It can be transformed to the squamous epithelium, especially those who are smokers, right? This is the one. And other one is the squamous cell. This is the squamous cell epithelium. Squamous cell epithelium, it can be convert, sorry, this is the column squamous cell only. So squamous cell is converted as a columnar cell. Okay, if this columnar cell is converted, what happens? It is going to increase the adenocarcinoma, right? It is going to increase the adenocarcinoma. And what is this example that I am discussing? That is the Barrett's esophagus. Barrett's esophagus. But Barrett's esophagus will be the benign condition. If it is progressed, it can cause the esophageal adenocarcinoma. And in the Barrett's esophagus, the classical findings will be goblet cells. Okay, goblet cells will be seen. To stain the goblet cells, what you can do the staining, guys? So the stain that we can use is the alkaline blue. Okay, alkaline blue. This is the stain that we can use for the goblet cells. Next, dysplasia. Dysplasia, just remember D for dysplasia, D for disorganized cells. And is it reversible? It is reversible. Okay, it is a reversible. Most of the in situ organisms and progression of the neoplasia early stages will be seen with the dysplasia. Right, next moving on to the irreversible injuries, and one among them is the examples of the coagulative necrosis, liquefatic necrosis, and other necrosis will be seen. And most common overall, that is a coagulative necrosis. And in the coagulative necrosis, there is a protein destruction. Again here there is a protein destruction, and most commonly the heart and patients those who are suffering from the MI, it will be associated. And also acids, bacterial infections, and dry gangrene. Okay, dry gangrene will be seen in these patients. Liquefatic, this is the second most common. And most of them will be the enzyme destructions. And the structure will be also damaged. So the structure destruction will be also seen in these patients. And where it involve CNS, most common type, and also all the types of the abscess in the body, and wet gangrene, alkalis. This will be associated with the liquefatic type. Next, fat necrosis. Fat necrosis can be traumatic type, and also some of them can be enzymatic type. And if it is enzyme, it can involve the momentum, and if it is a trauma, it can involve the rest. Okay, chalky white appearances that you are going to see. Chalky white appearances you are going to see. Gangrenous, just now I discussed, one is the dry, other one is the wet. Dry is going to be the coagulative, and wet is going to be the liquefatic. Next, caseous necrosis. Here you can see this is the caseous necrosis. And this necrosis is seen in the TB patients. Okay, most of the TB patients will be caseous necrosis. Fibrinoid necrosis. This is seen in the RHD, rheumatic heart disease, and also most of the vasculitis. You are going to see these conditions. Right. Next, moving on to the dystrophic calcification, and the metastatic calcification. In the patients of the dystrophic classification, the calcium levels is most important to discuss. Calcium levels here is a normal, and in the metastatic type, the calcium levels will be the increased. Okay, calcium levels will be increased. Whatever the conditions, these patients are deceased patients, and these patients are dying patients. Okay, most of them are already deceased patients and the dying patients where you are going to see. And whereas these patients is most of the time when they are presented, they will be normal only. So these normal conditions or incidental findings, you are going to see these patients with the elevated calcium levels. What are the examples? Here, the rheumatic heart disease is one of the example. MI, which is associated with the atherosclerosis, okay, with the association of the atherosclerosis, and patients those who are suffering from the TB and meningioma, okay, meningioma, papillary thyroid carcinoma, all this. Why these are important? Serous adenoma, this will be consisting of one of the most important one, that is the somoma bodies, right? Concentric circles, these calcium deposits that is seen in the somoma bodies. Whatever the examples of the metastatic, this is not a metastatic related to the cancer, so don't confuse with that. One of the examples is sarcoidosis, and other one is related to the vitamin D. If it is a vitamin toxicity, obviously calcium will be increased. And other condition, think about the physiology. If the parathyroid hormone is increased, then the parathyroid. So parathyroid diseases can be caused. And next, multiple myeloma. Right, multiple myeloma also we are going to see the patients will be having the elevated calcium. Next, milk alkali syndrome. Milk alkali syndrome also you are going to see elevated type of the dystrophic calcification that you are going to see. Next, coming to the apoptosis and the necrosis, and different types other also we are going to discuss. So first, the main differences that I want you guys to remember about is that this is a direct question that can be also asked most of the times: apoptosis and necrosis. So the difference between the apoptosis and the necrosis, this is always physiological and very rarely pathological. Like cancer cells, it can be pathological. And in the necrosis, the most of the times it is a pathological only. Not only most of the times, it is always pathological. That is the first differences that you have to remember. Next, moving on to the other, cell membrane. So the cell membrane here is going to be intact, and here the cell membrane is going to blast. Right, cell membrane is going to blast. And how it is going to blast? For example, if this is a cell, if it is going to becomes the very small, so what is this, guys? This is the pycnosis. Okay, so here also pycnosis will be seen, and rather than the pycnosis, it will be also converted in the karyolysis. So this is going to not sink, completely destroyed. So this is what we are going to see in the necrosis. Next, this is associated with the acute inflammation. No, there is no inflammation will be seen here. But here always it is associated with the acute inflammation. Inflammation is must seen with the necrosis patients. Okay. Next, what is the marker that we use here? CD95 and also Annex 5. We are going to use as a marker for the apoptosis. And here there is no specific marker that is present. And under the page, this is a test that we do. This is known as page test, like a spectrometry test only. So DNA ladder pattern. Here you can see this is a ladder pattern, right? So this ladder pattern is seen in the apoptosis. Okay, and necrosis, you are just to see the smearing, like inflammation, leaky contents that will be seen in the patients of the smearing. Next, how the pattern will be seen. Okay, most of the pattern, how the apoptosis is seen. So apoptosis, the definition of the apoptosis is the programmed cell death, right? This is the definition. So these programmed cell death, what does it will do? It has a two pathways. One is the intrinsic pathway. It is directly going to damage the mitochondria, and this pathway we have caspase dependent. This is the caspase dependent. What is the caspase that is involved here, guys? The caspase that is involved, intrinsic, remember it is 9. Next, it is the extrinsic pathway, and outside with the signals, with the receptors, it is going to damage. E for extrinsic, E for caspase 8. Caspase 8. This is for the extrinsic pathway. Next, intrinsic or extrinsic, you have to do the execution. That means completely you have to destroy that cell. So these execution is also depends on the caspase, and these caspase will be three, most importantly three, and other two are 6 and 7, also can be used as a execution. This is the apoptosis, and apoptosis we also have pro-apoptotic and anti-apoptotic. Pro-apoptotic bodies in our body which will tell to create the more and more. For example, this all will be named with a bad. Okay, and bam, puma, moxa, that will be pro-apoptotics. Anti, you have the BCL, MCL, whichever is ends with the L, that you can remember as a anti-apoptosis, that will decrease the apoptosis on the body. Next, we also have the necroptosis. So what is mean by the necroptosis? Necroptosis is nothing but whenever you are having a programmed cell type of a necrosis, that is a necroptosis. But this is caspase independent. This is caspase independent, and here they use the RIP 1 and 3 that will be used. Mostly viral, mostly patients those who are suffering from the viral infections, and also pancreatic conditions. Okay, pancreatic diseases. Necroptosis is used. Next, pyroptosis. Pyroptosis is depends on the caspase pyrogen, that is 1. This is the pyrogen, fever related. Next, ferroptosis. So the name itself telling this is going to use the ferrous, right? Ferrous is going to use, and for this is going to be the lipid destruction. Okay, the lipid cell membrane is destruction is done by the ferroptosis. Next, entosis. Entosis is non-macrophage cell. Non-macrophage cell destruction. That is the entosis. Next, FRO, FROcytosis. What is meant by the FROcytosis is cell life within other cell. Cell life within other cell. So that is known as a FROcytosis. This questions also different definitions has been asked previously in the examination. So please don't ignore those topics. Next, vacuotiners. This is a very small topic but very important also. So the red color which does not contain any anticoagulant, this is used for the serological examination. And this is the gray color used for the glucose estimation which contains the sodium fluoride. This is the lavender color EDTA. This is used for the complete hemogram and the ESR. Next, this is the sky blue which only uses the sodium citrate for the coagulation studies such as PT and APTT. Green color which contains the heparin. This is for the bone marrow studies. Yellow color is for the citrate, blood culture, and light pink color, this is the K280K. This is for the blood bank, ABO grouping. All this will be done for this vacuometers. Okay, these vacuometers should not be ignored because this is commonly asking the question in the examination. Okay, so that should not be missed, guys. Next, what is the most common stain that we use in the labs? So most common stain that we use is the hematoxylin and EC. Right, this is the most commonly used labs. Rather than that, for the glycogen or the glucose, we use the pass. Pass positivity will be C. Next, proteins. Proteins also, most of them will be pass positive. Next, the patients, those who are suffering from the different cancers also, we can use generally as a pass can be used. For example, lipids. If it is a lipids, we have to use the different one. That is oil, red, O color or Sudan black. Sudan black should be used for these patients. Next, for the copper. Copper, we can use the rhodamine for the rhodamine. And next, for the iron, we can use the Persian blue and pulse stain. Okay, pulse stain can be also used. Calcium. Calcium is used with the Voncosa and ulcerine red. Ulcerine red can be used. Next, also we have the melanin. So remember like a tan. So Mason Fontana. Next, collagen. This is recently in the NICT it is also asked. This is Mason Tricom. Mason Tricom. Next, amyloid. For the amyloid, we can use the Congo red color. Congo red color can be used. Mast cells, this is our Fmge PYQ only. Here we are going to use the thioridine blue color. Next, reticulocytes. For the reticulocytes, we have the supravital stains. Okay, supravital stains. In most of the blood related, we are going to use the Leishman and Giemsa. Listman and the Jimsa. This is the important stains that you have to remember. No matter what in the examination, these questions can be asked, guys. So you have to remember. Next, moving on to the inflammation. Okay, so basically the inflammation is divided into the two types, right? We have acute inflammation and other one is the chronic inflammation, right? So in the acute inflammation, what happens? Generally in the acute inflammation, this is the immediate onset, this is the immediate, and this is the delayed. And what are the cells that is involved? So if you want to know about the cells, you have to know about the WBC. So WBC is divided into the agranulocytes and also granulocytes, right? So this classification is not so important, but what are the cells? Never let eat the monkey banana. Never let eat the monkey. Never let the monkey eat banana. I'm sorry. Never let the monkey eat banana. So this is the neutrophils, which contains 70% of our red blood cells. Sorry, WBCs. Next, lymphocytes. This is around 50%, and these are the monocytes. These are 10%, and eosinophils, right? Eosinophils will be around 3%, and basophils are less than 1%. Sometimes 0 also seen. Okay, less than 1%. And which conditions these are elevated? That is also asked question previously. Okay, so which conditions these are elevated? Sorry. Let's see which conditions these are elevated. Neutrophils is most commonly these are elevated in the bacterial conditions, right? Lymphocytes, these are elevated in the TB or viral conditions, and even fungal conditions also this is elevated. Monocytes is also elevated in the bacterial macrophages production, and eosinophils is mostly associated with the allergens, and basophils also associated with the allergens. And rather than the allergens, you can remember this is associated with the cancers like leukemia conditions that will be elevated. So what are these components will be seen here? So in the acute conditions, most of the times there will be neutrophils. Okay, this is the immediate which will be coming. In the delayed type, there is no neutrophils because all the neutrophils are consumed here. So here you are going to have the second line, that is the monocytes. Monocytes will be coming here. And in the acute inflammation, so it is going to be the all symptoms, severe symptoms will be seen. Here, the symptoms are mild or not even present. Okay, this is mild symptoms will be seen. And which is going to be the repair phase? This is going to be the repair phase. After convalescent, we are going to have the repair phase will be seen. And here the repair phase is not seen. So this is the main difference between the acute and the chronic inflammation. So now let's see acute inflammation. What happens in the acute inflammation? So in the acute inflammation, so the most of the conditions is, let's take the bacterial condition only. Okay, let's take the bacterial condition. So this is the faster action it should be have, and also it should be have the short, right? Short acting, faster acting will be seen with the acute inflammation. Let's see one by one. First, this is the normal axial flow, and once there is a pathogen is seen by our cells, what happen? There will be going to margination and the pavementing, and after that rolling and adhesion and immigration and the diapedesis. So they are divided into the two types. One is the vascular events and other one is the cellular events. So ascending order is also asked in the previous year examination. If you see the previous, ascending order is asked. So in the vascular events, let's see. So the vascular events are three types. Earliest, the first and foremost earliest, if there is an infection, this will do the vasoconstriction, very transient vasoconstriction and very limited vasoconstriction. Immediately after that, you are going to have the vasodilation, where this is a vasodilation, first noted event that we can know. And after that, there is a vascular permeability. Okay, vascular permeability. So these vascular permeability is known as a hallmark. Okay, this is known as a hallmark. And after the vascular permeability, there are the smooth muscle cells which is going to contract, and all the blood will be pooled at the one spot, that is known as a stasis. So these are the vascular event. Next, followed by the cellular events. So followed by, there should be the cellular event, and the most important cell is the WBC cell. This WBC cell has to act. So what is that event first? Followed by the vascular, there is a margination. Okay, there is a margination, and this margination is followed by the rolling, and rolling after we are going to have the adhesion, and after adhesion pavementing, followed by the, these are the important immigration points and the diseases that you have to remember in this and condition. Those who are new to this channel, please do subscribe. That means it's already crossed the endothelium. Then after the diapedesis, there is a chemotaxis followed by the phagocytosis. Okay, phagocytosis. This is the pattern. Okay, these ascending order should not be missed, guys. Okay, very important. But I want you guys to take note of this particular events. Right. Next, what are the important points that you have to take note in this pattern? So they are, every phase has the important points. For example, let's take the rolling. So rolling is done by the selectins. Rollings are done by the selectins. What are the selectin that is acting here? We have the E, we have the L, and we also have the P. Okay, E and L is going to, sorry, let's write like this: E and P and L. So these E and P is going to act on the two important points, that is the Cialis in our circulation only. On the endothelium, there is a factor that is a Cialis Lewis X factor. On this factor, this E selectin and P selectin is active. Next, L selectin is going to act on the glycom 1, and CD34. Other name is a glycom 1 and the CD4. Remember, like glycom, LL, there is a glycom. Next, after the rolling is done, right? Next, we have the adhesion. Adhesion means tight, that you have to hold. So this is done by the other two, that is a beta 1 and beta 2 integrins. Beta 1 and beta 2 integrins. Okay, And beta 1, beta 2 integrins, beta 1 will be done by the VCAM1. Beta 2 is done by the ICAM1. Okay, this is the one, not the I, don't confuse. ICAM1. And after the addition, we have the last step, that is a diapedesis. Right? This is the diapedesis. Diapedesis is done by the PECAM1. PECAM1. So these are the important points that you have to remember. I will just highlight with the other color. Okay. So rolling, addition, and diapedesis. They are important. There are other points also you have to take note. Next, we have said here there is a chemotaxis. Chemotaxis also have the two types. Chemotaxis also have the two types. One is the exogenous chemotaxins and the other one is the endogenous chemotaxins. Exogenous is mostly bacterial only. Okay, and endogenous we have from our body only. Remember with the mnemonic of the LIC. Okay, remember with the mnemonic of the LIC. What is this? This is the leukotriene. Okay, leukotriene B4 that is going to be act here. Next, IL8. Okay, IL8 and complement. This is the C3A. C3A. So these three are going to act as the chemoattractants for the bringing those particular from our towards our body to kill that pathogen. Okay, that is the one thing that you have to remember. Next, how the phagocytosis. The last events of the phagocytosis, one is the O2 dependent, one is the O2 dependent, other one is the O2 independent. So the most common will be the O2 dependent. This is the most common with the help of NADPH, right? With the help of the NADPH, the killing will be done by the phagocytosis. Next, moving on to the other important cells that I want you to take note. Serotonin action. What is the serotonin action? Serotonin action will be the vasodilation. Next, vascular permeability. This shortcut has to be, don't want to confuse guys. Platelet aggregation. Platelet aggregation. Serotonin. Next, histamine. Histamine, vascular dilation, vascular permeability. These two are also done by the histamine only. Next, we have platelet aggregating factor. Obviously, the name itself telling. So this is going to increase the platelet aggregation. Along with that, vasoconstriction is done. If you want to aggregate, later on it will relax. Vasodilation is seen. So multiple actions is seen by the platelet activating factor and also vascular permeability. Next, we have the sodium, sorry, not sodium, this is the nitric oxide. Nitric oxide is acted by the CGMP, right? It is going to act by the CGMP. So nitric acid is going to also do the very potent vasodilator, right? And smooth muscle relaxant. This is the main action. Next, we have the substance P. We have the substance P. What does the substance P will do? It will increase the pain. Pain will be seen with the substance P. So these are the some factors that you have to take note. Right? Next, moving on to the chronic inflammation and other factors, interleukin, cytokines. I will be explaining in a while, but please take note of the chronic inflammation. So these chronic inflammation, what does it will be? It will be delayed, right? It will be delayed and slow. The main hallmark, the main hallmark of this particularly the chronic inflammation will be tissue destruction. Okay, it is going to do the tissue destruction, which will be done by the chronic inflammation. How the tissue inflammation destruction will be done? With the formation of the granuloma. With the formation of the granuloma. And how this granuloma is formed? So these granuloma is formed with the help of the macrophages and also interferon gamma and also interleukin 8. All this will be playing a major role to increase the macrophages, to increase the granulomas. And how the granulomas are presented. Here you can see this is the granuloma. So the middle one is going to be the necrosis, and along the side of the necrosis you will be seeing the epithelioid histocytes. So these are the epithelioid histocytes. Next, surrounding with the lymphocytes and multinucleated giant cell. One cell consists of the multiple granules, that is known as a multinucleated granules. What are the granulomas? Types of the granulomas, let's see. One most common in India today also, if you test, the most common one will be the caseating necrosis, where you are going to see, obviously this is seen in the TB and also patients those who are suffering from the histoplasma in Western countries and HIV patients. Non-caseating, non-caseating type. This is seen in the sarcoidosis and leprosy. This is the never make the mistake. Mycobacterium leprae is seen in the non-caseating. Mycobacterium tuberculosis is seen as a caseating necrosis. Next, Durex granuloma. This is seen in the cerebral type of the malaria. Okay, CNS type of malaria. Next, Langhans type. Langhans type is seen in the TB, and again in the recent INICT it is also given Langhans cells where you see TB is no option. The one option that you have to choose is the similar to the infection, that is the histoplasma. Next, donut shaped. Okay, donut shape. Where is the donut shape is seen? This is seen in the Q fever. This is seen in the Q fever. Next, there is a non-immune type also, non-immune type of the granuloma. This is seen in the silicosis. Star-shaped, star-shaped, or we can also call this as a stellate-shaped. So, stellate-shaped is seen in the Bartonella and LGV, lymphogranuloma venerum. This condition also seen. Next, Redstenberg cell. Redstenberg cell. This is a not a granuloma. Just I want you to include here. That is the Hodgkin lymphoma. Hodgkin lymphoma. Right? These are the important granulomas that you have to remember. Next, also, I want you to remember here the different types of the cells. For example, Kupffer cell. Where is this Kupffer cell is seen? This is seen in the liver. Right? Next, sinusoid cells. Sinusoid cells is seen in the spleen. These are seen in the spleen. Next, other cell. Other important cells such as brain. What does the brain contain? Microglia. Microglia. These are present in the brain, right? Brain structures will be consisting of the microglia. Placenta also have, because placenta should not transmit the infections to the baby. So they have the Hofbauer cells. Hofbauer cells. Next, we also have the dust cells. The name itself tells it is a dust that will go into the pulmona, right? Pulmona, like pulmonary, you are going to see. Next, mesangium. You may have already heard of the mesangium that is seen in the kidney. Next, osteoclast. Osteoclast, this is seen in the bones, right? Osteoclasts will be seen in the bones. These are the some of the neutrophils formation in the different organisms. I'm sorry, different organ systems. Okay. Next, coming to the other points that you can remember here is the how the granular tissue repair is going to happen. Tissue repair is going to act. So remember the timeline, less than 24 hours. There is an inflammation. If there is an inflammation, obviously there are cells that will be going there. Those are neutrophils. Next, less than 3 days. Here, the maximum tissue is formed here. So the maximum tissue is formed and neovascularization is done. And also collagenation is done. Next, more than 7 days. Here, the maximum tissue is formed with scar, and more than 2 weeks, so the scar completes. Okay, more than 2 weeks or 1 month. But how much strength will be seen? So only 80% strength will be seen. Okay, 80% strength only seen. And first, it is going to be the third collagen. It will be replaced with the first collagen later. Okay, so this is the early in the wound only I'm talking about. This is a late type of the collagen that we have. All right. Next, I want to say some of the interleukins, important interleukins that we have to discuss. but there is no place here. So we will be discussing here. Okay, so just see the important points about the different types of the interleukins and the cytokines. All right. So the first and foremost, what is the pro-inflammation and what are the anti-inflammation? So we have the body. So they are promote some of them will be decreased. So the promotion will be done by the interleukin 1, interleukin 2, interleukin 10. Okay, even interleukin 4 and 6. Next, anti-interleukins are interleukin 4 and 6 and TGF beta. Here it is TGF alpha and also interferon gamma. These are the common. And if you observe interleukin 4 and 6, they both active. They are pro and they are also going to be the anti. Next, going to be the cachexia. So in the body of the cachexia, so especially cancer patients, you are going to see the TNF alpha. Next, for the granuloma formation, just now we discussed interleukin 8, 12, interferon gamma. Right? These are the important. Next, fibrosis in the body. Right? Especially during the wound repair. So that is going to be the TGF beta. That is the TGF beta. Next, eosinophils. Eosinophils have the specialized cells. Those are the interleukin 5. And neutrophils is interleukin 8. Monocytes, or we can say macrophages, this is interleukin 12. Okay, these are the important cytokines also that you have to remember, guys. Next, moving on to the next chapter, that is the immunology. Okay, immunology that we will be discussing now. So just now we discussed what are the cells, right? We have the two types. Again, here also we have the two types: innate immunity, and adaptive type of the immunity. So in the innate immunity, this is the acute, and I can say this is the immediate, and this is the first line of the defense. This is the late, but this can act also functional like second line. So there is no word as the immediate or that, but this is the adaptive type. So how this innate and the adaptive types will be working? So innate are most commonly whichever we already had from the birth. But the importance of this is there is no memory. So no memory cells. So long time you can't be worked. But adaptive immunity, so this is acquired. This is acquired while we are exposing that. And next there is a memory cells and also helper cells. All these cells will be present in the adaptive type. So here we are seeing the innate immune cells. So how these innate immune cells will be working. So here you can see the mast cells, basophils, eosinophils, macrophages, T cells, dendritic cells, all these cells are going to be act in the different kinds of the immune cells. For example, if you see the eosinophils and the basophils, they are going to act on the allergens, right? This is going to act on the bacterial, and these are also going to act on the bacterial. Next, we also have the two types of the cell mediators. One is the T cell and one is the B cell. So what is the T cell, guys? This is a cell mediated type. Next, what is the B cell? That is the humoral type. So these have the T helper cells and also they have the memory cells. B cells, they are going to produce the immunoglobulins. They are going to produce the immunoglobulins. So next we have the classification. Let's see the classification, the importance classification that I want you guys to understand. First, we have the MHC classification. First, this MHC classification is going to form the major HLA classification. Okay, so they have the two. One is the CD4 and other one is the CD8. According to these both only, the main helper and killing will be done. So CD8 will be mostly with the killing cells. Okay, this will be presenting with the killing cells. And what is the MHC that they are associated? MHC complexes. Just remember the rule of 8. How this rule of 8 is? MHC 4 means I have to add here MHC 2. 2 4 is 8. And if I want to add for the 8, that is the MHC1, right? This is the classification. You can remember rule of 4, rule of 8. Next, how the structure will be presented. So this is the receptor. So here is the receptor. So alpha 1, beta 1, alpha 2, beta 2. So here the pathogen will be forming. Next, here alpha 1, alpha 2, alpha 3, beta 2. Here the pathogen. So where the pathogen is forming here? Alpha 1 and beta 1. And what about here? Alpha 1 and alpha 2. This question is also has been asked. Next, recently they asked where is the staphylococcus will be forming. So staphylococcus toxin is going to be present on the lateral border of the MHC classification of beta 2. Okay, sorry, this will be in the this side here. So they will be presented in the here. There will be, if there is a toxin produced by the staphylococcus, that is present here. Remaining all will be presenting on the top of the receptor. Okay, next, T cells. So let's see the different types of the T cells. We have three types of the T helper cells. One is the T helper 1, 2, and 17. So 17 is for the acute infections. 1 is for the chronic infections, because interferon gamma is going to be the chronic, right? And next 2 and 13, this is for the allergens. This is for the allergen types. Okay, the one thing that you have to remember. Next, how these cells are going to activate it. How these cells are going to activate it, because we have to act by the immunoglobulins, right? How the immunoglobulins are activated. For example, this is the B cell. Let's say this is the B cell, and B cell has a special ligand. B cell has a special ligand. That ligand is a CD40. And next, T cell. This is the T cell. T cell is also going to connect with this, particularly this structure, that is the CD40. So once the CD40 is connected, this is has been sending the signals. So the signals are coming from the T cell to the B cell to produce the more and more immunoglobulins. Once they are activated, they are going to produce the IgM. IgM will be produced. After that, the first one is IgM. So the second one will be the IgG, followed by the IgA, D, and E will be produced. So let's see what are the importance of these cells. IgG and IgM. IgM is a pentamer. Okay, IgM is a pentamer. This is the monomer. This has the maximum weight and not cross placenta. Next, IgG has the maximum distribution and they cross the placenta. And once in the life, if you get the IgG, that will stay for the lifetime. And IgG, another point that you have to remember, the G1 is the most common and G2 is most common for the capsulated organisms. Capsulated organisms, this is the most common type of the G2, IgG2. Next, IgA. IgA is present in the breast milk, right? Breast milk, saliva, other secretions also it is present. IgD, this is present in the B cell receptor. IgE, IgE is present in the mostly allergic reactions such as anaphylaxis, asthma. These patients you are going to see the IgE, right? These are the important points that you have to remember, and interleukins that I have explained already above. That questions also has been asked. Next, other one that you have to remember here is the NK cells. NK cells. NK cells are innate immunity. These are the type of the very first innate immunity that we have had. And for the marker, this is the CD16. CD16 is a marker for them. And these are active for the viral infections. Viral infection and most of the tumor cells. But they are very less, 20% of the body only. So most of the has to depend on the B cells and the T cells only. We have to remember, depend. Okay, that is how we have to depend. Next, we also have the toll-like receptors. Okay, toll-like receptors. So these toll-like receptors is going to save from the different types of the infections. For example, toll-like receptor 2. This is for the TB. Toll-like receptor 3. This is for the DNA viruses and RNA viruses. Okay, 1 point. And next, we also have the toll-like receptors 4. This is for the gram negative. Toll-like receptor for 5. This is for the flagella. Toll-like receptor, this is 9. This is for the protozoa. Right? These some of the points of the toll-like receptors and the examples are also important. Next, moving on to the hype, that is graft. So transplantation medicine that we are going to discuss. Isograft means same person. Next, we have the autograft. This is for the same person. Autograft is same body. So isograft is for the same identical twin. Right? Then we also have the xenograft. Xenograft is from the animal. Xenograft is from the animal. But whenever we are doing these grafts, we are going to have the reactions. So that reactions is divided as a hyperacute, hyperacute. This is seen less than minutes to hours. Why? Because they are already having the bodies, antibodies, performed antibodies, they already formed. So pre-formed antibodies that is going to cause this reaction. And this is comes under the type 2 hypersensitivity reaction. Next, we have the acute. Overall, the most common is the acute only. And this takes weeks, okay, weeks to months. And this is also associated with most of the times this is a T cell mediated. Okay, T cell mediated. So this is type 4 hypersensitivity reaction. Next, we have the chronic. This is like years, delayed type. And delayed type is again type 4 hypersensitivity reaction. Next, graft versus host disease. So graft versus host disease, this is also type 4 hypersensitivity reaction. Here the graft is deleting our body. So first here we are deleting this graft, and now the graft itself is deleting us. And mostly this is associated with the skin, GIT and lymph nodes involvement. Okay, this is with the graft versus host disease. Next, another important point that you have to remember here is the allergic reactions. Okay, allergic reaction. Allergic reaction, this is IgE mediated. Here you can see this is how IgE receptor is going to release the granules from the mast cells, so that is going to act with the help of the T helper cells. Okay, next type 2. Type 2 is mostly cytotoxic. This is the cytotoxic reaction. Mostly antibodies are formed. Here antibodies is going to destroy. And this is related to receptors. Receptors is going to destroy, and sometimes it can be phagocytes that is also going to destroy here. Next here it is immune mediated. So if it is immune mediated, both the antigen and the antibody, so immune complex is formed. Next, this is a delayed type. In the delayed type, we are going to see the T cell mediated, right? This is a T cell mediated immune response will be seen. And these examples will be, I will be explaining in the other slides. So next, moving on to the another condition, this is the amyloidosis. Okay, amyloidosis will be contents of the beta sheets. This is contents of the beta sheets, and the size is 7 to 10 only. The size is very less. Next, what is the most common type? The most common type is the AL. This is the primary amyloidosis. AA, this is the secondary types. In the secondary type, it is associated with the rheumatoid arthritis patients. Next, they are the family conditions also, familial related conditions. So familial Mediterranean fever. So familial Mediterranean fever, where this is presented, this familial Mediterranean fever that will be consisting of the proteins like amyloid only, that is going to present here. Next, familial polyneuropathy. So familial polyneuropathic syndrome, this is present with the ATTR. This is present with the ATTR. Next, we also have the kidney. Kidney is most commonly involved. that is going to involve the beta 2 microglobulin. Two kidney you have, that is a beta 2. If it is involves the brain, only one beta amyloids will be seen here. If it is associated with the prions disease, PRP, that is with the prions disease. Medullary carcinoma, right? Medullary carcinoma that is associated with this one, that is calcitonin. That will be calcitonin. If it is a heart, it will involve again transthyretin, transthyretin that will be seen in the cardiac also. So these are the some of the important points, and where how you are going to check the amyloidosis. We can check for the positive also. We can check the glucose iodine also. But the best one will be the Congo rate. The best one will be the Congo rate. On the light microscopy, you are going to see this as a pink color. Okay, pink color will be seen. And under the fluorescence, you are going to see is the green color. Okay, green color will be seen. This is the Congo rate that is for the amyloidosis. All right. Next, neoplasia. In the neoplasia, we have to again take note the difference between the benign versus the malignant. Benign versus malignant. So here the cell proliferation is less comparing to the malignancy. Here the cell proliferation is very much high. So the cell proliferation is too much high in the malignant types. And here the polarity is normal, but here the polarity means the differentiation between the two different cells. It is not present. Okay, completely different. And the basement membrane is intact, and here the basement membrane is invaded. Okay, basement membrane is invaded, and no meds. Meds is not seen here, but here the meds are seen. So that means the malignancy hallmark. If I say the hallmark, the hallmark is the metastasis. If the metastasis is present, then that is likely to be the most commonly malignancy condition, right? So here you can see this is the neoplasia, abnormal excessive growth, and most commonly this is the anaplasia. Okay, you can't differentiate which cell is which. That is the anaplasia. Next, we also have the here the dysplasia, disorganized type, right? Pleomorphism, loss of polarity. All this will be seen in the most of these conditions only. And how this neoplasia will be occurring in our body. So mostly we have to understand here about the cell cycle, how the cell cycle is formed. So we are most of the cells will be in the resting stage, and from there they are going into the starting to the synthesis G1 followed by the S phase. Okay, and after the S phase they are going to enter into the G2 phase, and then M phase, and back to the resting phase. Okay, this is how the cell cycle will be working. So this is divided into the two types, right? Next, what is this above phase? This above phase is for the synthesis, and this below phase is for the mitosis. Okay, above phase is for the synthesis, below phase is for the mitosis, and they are cells that will be present here. Those are cyclins. Those are the cyclins. What are those? D, D, E, A, B. They have the receptors also. What are those receptors? 2 and 4 and 4 and 2 and 1. This is the presentation. So this is for the G1, this is for the G2. Okay, this is for the G2 and this is for the G1. That is what the cyclins that is going to act. And there are some of the cells also present here. For example, G1 to GS, G1 to S phase. So there is a break, that is a gatekeeper. What are those? That is P53 and the RBG. Next, G2 to M phase. They also gate. So here only P53. Okay, P53 and RB, that is for the G1S, and G2 and SM is the only P53 gene will be present here. So this cell cycle is also very important to understand. Apart from that, these cells is very naturally they are having the many properties. What are those? For example, we just now discussed they are the pro and apoptotic, right? That means they are actually wanted to do the pro apoptosis, but they are going to block this pro apoptosis. So these cells pro apoptosis is blocked by the malignancy. So malignancy cells is going to block this pro-apoptosis. That means if you avoid the apoptosis, there will be more growth. So the more growth will be seen. And next, proto-oncogenes. Okay, proto-oncogenes. These proto-oncogenes, which will be acting same in the cell cycle only, and this will increase the more and more growth. And there will be neovascularization. So vegetative endothelial growth factors that will be activating new vascularization will be seen. So that means angiogenesis will be seen, and tumor suppression will be the tumor suppression genes we have. So what happens to these genes? These genes are not going to act. So there is a acting of these genes will be also decreased. So how about food? They need every cycle, every cell need the food also. So for the food, they are going to use the aerobic glycolysis. Aerobic glycolysis. How this aerobic glycolysis is going to work, guys? So most of the aerobic glycolysis, which will be working with the help of the Warburg effect. Okay, Warburg effect. So what is mean by the Warburg said that these cells is going to use the aerobic. Okay, aerobic, but they are going to enter the lactate because the less energy is consumed. So to consume the less energy, the cells is going into the aerobic glycolysis and producing the lactate. This is the Warburg effect. Next, Knudsen hypothesis. So what does the Knudsen hypothesis is said that this is about the RB gene. This is about the RB gene. So what happens in the RB genes? They are usually is present at the G1, right? They are present in the G1 phase. In the G1 phase, they has to active. So if they are active only, they are going to stop the cancer cells. How they are active? They are actually hypophosphorylated. Hypophosphorylated. So they are in active stage. If there is a mutation, so what happens? This active phase is going to be inactivated by adding the phosphorus. So if you add the phosphorus, they are going to be the hyperphosphorate. So the cell will be inactive. So high chance there will be coming of the cancer cells. So this is also one of the factor. Next, spread to the other structures. How the spreads will be seen? With the help of the metastasis. For example, CSF. This is going to be the direct, and also abdomen with the ovaries. It is going to be the direct, and using the lymphoma, lymphatic, and hematogenous. All these spreads will be seen with the different types of the spreads of the metastasis that is going to be seen. Next, here we will be discussing about the radio sensitive versus the radio resistant. Okay, so radio sensitivity is seen with the G2M, and radio resistant is seen with the G1. So this is seen with the G1 and the S phase. This is seen with the lymphocytes, and also bone marrow, very sensitive, gonads, and here it is vagina and neuron, and also the cells like brain. Okay, brain, platelets, platelets. They are very much resistant. They can't be killed also. So let's see the examples from the here, guys. First, type 1 hypersensitivity reaction examples are hay fever, Prasnitz reaction, Schwarzschild phenomena, Cassoni test, food allergy, allergic rhinitis, bronchial asthma. Type 2. It can be sometimes known as a type 5 also. Myasthenia gravis, blood transfusion syndromes, and good pasture syndrome, Graves disease, immune related uh, hematolytic anemia and thrombocytopenia, and also Rh disease, rheumatic heart disease, pemphigus vulgaris, and the pernicious anemia. Type 4 is associated with the immune complex mediated SLE, CM sickness, and HSP, Arthur's reaction, reactive arthritis, rheumatoid arthritis, PSGN, and the lepra type 2. Next, delayed types. What are those? Tuberculin, multiple sclerosis, lepra type 1, contact dermatitis, and the type 1 diabetes mellitus. Right? Next, coming to the genes, oncogenes. RAS-K is for the colon cancer, RAS-H for the RCC, that is the renal cell carcinoma, RAS-M is for the melanoma, ABL is for the CML, BRAF gene is for the hairy cell leukemia, MIG-C is for the Burkitt's lymphoma, MIG-N is for the neuroblastoma, MIG-L is for the lung carcinoma. Cyclin D is for the mental zone lymphoma. PDGF is for the astrocytoma, FGF is for the osteosarcoma and the fibrosarcoma, HGF is for the hepatocellular carcinoma, PDGFR is for the glycoma, and EGFR1 is for the adenocarcinoma of the lungs. Another EGFR2 is for the breast cancer. Red gene is for the importance like Men's syndrome 2A and 2B. HIT is for the GIST, AML, melanoma, and seminoma. ALK is for the again adenocarcinoma of the lungs. Glioblastoma is for the CDK4. Next, tumor suppressor genes. P53 is going to cause the Log-Freeman syndrome. RB gene is destroyed, then it can cause the retinoblastoma. NF1 is for the neuroblastoma, NF2 is for the schwannoma. Chromosomes is rarely asked, don't have to be focused that BRCA1 is for the breast cancer plus the ovarian cancer, and BRCA2 is for the male and female. Both are going to have the BRCA2 mutations. WT1, WT2 is for the Wilms tumor, VHL is for the renal cell carcinoma. That is renal Hepel syndrome. Next, tumor markers. Calcitonin is for the medullary carcinoma, AFP is for the hepatocellular carcinoma and the yolk sac tumor, beta HCG is for the germ cell tumor, and also choriocarcinoma, right? Choriocarcinoma also we are going to check with the beta HCG. PSA is for the prostate carcinoma, catecholamine is for the pheochromocytoma, CEA is for the colon and the pancreatic carcinoma, CA72 for the stomach, CA19 is for the colon, and pancreatic best is the pancreatic for the CA19, CEA is best for the colon. CA15 is for the breast and CA125 is for the ovarian carcinoma. And aflatoxins is going to cause the HCC. Aromatic amines such as benzidine is going to cause the bladder cancer. Ionizing radiation can cause the leukemia, and especially which leukemia is most common? ALL is most common. Next, nickel, chromium, beryllium, silica, radon. This can cause the lung cancer. Arsenic, vinyl chloride, and also thorocrust. This is for the hepatic angiocarcinoma. Let's see some of the examples for the genetics. Prader-Willi syndrome. Here the Prader-Willi syndrome, P for Prader-Willi and P for paternal gene deletion, and maternal is going to be the disomy. Whereas Angelman, A for Angelman and Amma, let's say maternal deletion, this is going to be the paternal disomy. Next, mitochondrial inheritance. Mitochondrial inheritance, see this cycle, all the generations are involved, and but the disease is forming coming only from the mother. So the disease is transmitting only from the mother, not from the fathers. See, the fathers are not transmitting, only the mothers are transmitting their children. So that is a mitochondrial type. And what are the examples? One of the best example is the MELAS. Okay, this is the most common. NARP syndrome, Weber, Heroptic neuropathy, ophthalmoplegia. These are the some of the examples. Trinucleotide repeats. Huntington's chorea, CAG, Fragile X, CGG, Friedreich's ataxia, GA, and spinocerebellar is going to be the CAG. Okay, next, Mendelian patterns. Autosomal dominant. What you have to remember mostly, all generations will be involved. That is the first point. And second one, there is an incomplete penetrance. For example, if the disease is transmitted to you, you may show the severe symptoms and other person is going to show the less symptoms. So that is the incomplete penetrance. One person to the other person, the penetrance will be less. Variable expressivity, same. The symptoms will be different from the one person to the other person with the same disease. Next, autosomal recessive. Autosomal recessive, this is going to be risk with the within the family marriages and commonly associated with the enzyme defects. And one generation will be having the carrier, other generation will be having the disease. For example, this stage is going to be the carrier, this stage is going to be the disease. That means this generation is skipped. So that we only see in the autosomal recessive. Next, X-linked dominant. X-linked dominant, father is going to cause for the daughter. Again, only the father is going to cause for the daughter, that is going to be the X-linked dominant. X-linked recessive, if mother is going to cause for the son. Okay, so the mother is going to cause for the son, that is going to be the X-linked recessive. Examples, let's see the examples. Autosomal dominant examples are the dystrophia myotonia, osteogenesis imperfecta, neurofibromatosis, tuberous sclerosis, hereditary spherocytosis, achondroplasia, von Willebrand disease, Ehlers-Danlos syndrome, ADPKD, and intermittent porphyria and Marfan syndrome. Autosomal recessive conditions are alkopcinuria, beta alpha cell thalassemia, cystic fibrosis, deafness, emphysema, Friedreich's ataxia, Gaucher disease, and the homocystinuria. X-linked dominant examples are most important Fragile X syndrome, Charcot-Marie, Alport syndrome, rickets, which is a resistant rickets, and the Rett syndrome. X-linked recessive, these are mostly like your conditions like a G6PD, DMD, Fragile X syndrome. Best is a Fragile X syndrome, choose to be in the X-linked dominant. Okay, chronic granulomatous condition and Bruton X are also known as a gamma-globinuria, and hemophilias A and B, color blindness, Wiskott-Aldrich syndrome. Those are the X-linked recessive conditions. Next, anemia examples that we are going to see. If you see these kind of the target cells, if you see this kind of the target cells, that is seen in the thalassemia. Beta thalassemia is more common than the alpha thalassemia. Next, beta thalassemia major. Just now we discussed this is associated most common type of the variant of the thalassemia, and they are going to present with the target cell. How the target cell will be seen? Here you can see. So there is a middle cell and the differentiation. Middle has to be pale, but here it is going to be associated with the pigmentation. That is the target cell. Next, lead poisoning, which will be seen with the basophilic stippling. Okay, this kind of stippling will be seen in the lead poisoning. Next, megaloblastic anemia, mostly associated with vegans B12 deficiency, and the homocysteine levels, methylmalonyl-CoA levels will be elevated. And on the picture, the megalocyte will be seen multinucleated or the hypersegmented neutrophils, and basophilic stippling will be seen. Whereas folate associated, the methylmalonyl-CoA levels are normal only. And same macrovalocytes, hypersegmented, oval jolly bodies, these both are going to be having the same only. Aplastic anemia. So there will be dry tap. Okay, here you are going to see fats but no cells. So that is known as a dry tap. Next, hemolytic anemia. Spirocytes will be seen. Okay. Next, G6PD. On the G6PD, you are going to see this kind of hens bodies that will be seen. Bite cell. Okay. So the cell is got bite. These are the bite cells. Next, hereditary spirocytes complete. There is a pigmentation in the cell. It has to be pale, right, in between. So there is no pale. So the differentiation here you can see the differentiation between the different types. But the one thing that you have to remember, ankyrin is most common. You also have the spectrin. Don't choose the spectrin. Ankyrin is the most common. What is the test that we are going to do? Osmotic fragility test that we are going to perform here in this patient. Autoimmune hemolytic. Warm is associated with the G. Remember, like Garmi is warm. Direct Coombs test is positive. And hemolytic cold is for the IgM. Same. Direct Coombs test is positive. Sickle cell anemia, like this. Sickle shaped cells will be seen. And what is here? What is the position? That is sixth position. Beta and glutamate is gone. Let's say glutamate is delete and it is replaced by the valine. Okay, valine like welcome. This is important point of the sickle cell anemia. Next, another points like iron deficiency anemia. These are the pencil cells. Okay, these are the pencil cells. And iron, ferritin, T percentage transferring levels are decreased. PABC is the only is going to increase. Sideroblastic anemia just opposite to the iron deficiency anemia. Ferritin, iron, T transferring is elevated. TIBC is decreased. Anemia of the chronic disease, this is most of the times will be normocytic. And why this is happening? This is due to hepcidin action. The more and more hepcidin action that is going to be presented. So that's why iron is elevated, whereas ferritin that is decreased, right? Sorry, vice versa. Right, this is the iron is decreased, whereas ferritin is increased. That is seen in the anemia of the chronic disease. Menzer index, if it is a less, there is a thalassemia. If it is a high, iron deficiency anemia. Okay, AM. The points that you have to remember about these disorders are only what are the positive. If it is a MPO and if it is a 15 and 17 is present, APL gene that is present, this is the AML, most commonly seen with the adults. ALL is seen in the children, associated with the 12 and 21 translocation, and this is having a good prognosis. Next, CML. CML is present with the Philadelphia chromosome, BCR and ABL. What is the drug of the choice for this? Imagine it, tyrosine kinase inhibitors. CLL, which will be presented with the smudge cells, CD5, CD20 B cells will be the positive of this condition. And Richner transformation is seen with the CLL. What is the Richner's transformation? It is going to convert into the lymphoma. From leukemia to the lymphoma, that is seen with the CLL. Next, Hodgkin lymphoma. In the Hodgkin lymphoma, the most common India, that is the MCHL, and the worst one and the worst prognosis, that is the LPHL, and very good prognosis is going to be the NLPHL. Next, EBV. EBV is associated with all types, guys. EBV is associated with all types except NLPHL. So here I given the 0%, so but still it is 2%. At least NSHL is associated, but NLPHL is never associated with the EBV. That is the one thing that you have to remember. And where you are going to see Redsteinberg cell, popcorn type is NLPHS cell, Bacunar is NSHL, mononuclear MCHL, classical type is the LRHL, and whichever is a not, that is the LPHL. Next, again translocations. Burkitt's lymphoma, 8 and 2, 8 and 22, 8 and 14. Marginal zone, 11 and 18. Mantle zone, 11 and 14, and Sox 11. Germinal center, follicular lymphoma, 14 and 18. These are the important translocations that you can remember easily from the question itself. Okay, starry sky appearance. This is seen in the Burkitt's lymphoma. Right, this is seen in the Burkitt's lymphoma. Multiple myeloma, important points. For example, 4 and 14, that is seen in the translocation of the multiple myeloma, 11 and 14, 14 and 16. And on the plasma peripheral blood smear, you see this kind of Rolox formation of the RBC. And on the bone marrow biopsy, you are going to see the M protein that will be elevated. And why this condition, plasmacytoma with this condition will be occurring? Because of immunoglobulins is raised. On the serum electrophoresis, you are going to see the M spikes. Urine, you are going to see the benzones protein, elevated calcium, ESR and beta 2 microglobulin. And on the X-ray, the lytic lesion. This is the key, lytic lesion, punched out lesions with the pain, with the elevated calcium. Just remember, it is going to be the multiple myeloma. Next, lung cancers. In the lung cancers, that is a squamous cell carcinoma, mostly involves the central zone, and this is not the most common, guys. Nowadays, the most common cause will be is recently updated, that is the adenocarcinoma. Okay, and this is mostly associated with the smokers. This is non-smokers and severe smokers. Okay, severe smokers. That is a small cell carcinoma. And P53 mutation, ALK, EGFR2, FR1, LMYC, and the CH3P. That is a small cell carcinoma. The paraneoplastic syndrome, hypercalcemia, migratory thrombophlebitis, SIADH, and the Cushing syndrome. And immunohistochemistry, this is very important. Cytokeratin is positive for the squamous cell, and TTF, napsin A is for the adeno, and more important, this is chromogranin synaptophysin bombesin is for the small cell carcinoma. Next, coming to the histology, here you can see the onion and the keratin pulse that is seen in the squamous cell carcinoma, and here the lepidic pattern. Okay, this is known as a lepidic pattern seen in the patients of the adenocarcinoma, and azupardi, like distinct, okay, the severe proliferation that is seen in the azupardi, like salt and pepper appearances. Here you can see this is like a salt, suddenly there is a thickness, suddenly there is thickness, suddenly proliferation. So salt and pepper appearances that is seen in the small cell lung carcinoma. Next, myocardial. So the most common, the first one which will be elevated is ischemia modified albumin, followed by the heart fatty acid, and followed by the myoglobin. If these two options are not given, then choose the myoglobin. What is the most sensitive marker? Then that is the troponin I. Why this is most sensitive? Because it is elevated up to 7 to 10 days, and also re-infract also seen. Next, coming to the morphology. On the gross less than 10 minutes, 30 minutes, you are not going to see anything under the gross or the light microscopy. Whereas in the electron microscopy, there will be swelling. Like this is the reversible changes. 30 minutes to 4 hours, there is a waviness of the myofibrils on the light microscopy and amorphous densities. That means it is already irreversibly damaged with the help of the necrosis. Next, day 1 to 3, it is going to be the neutrophils and coagulative necrosis. Day 3 to 7, lymphocytes and the macrophages. Day 7 to 14 is the granulation tissue. Day 28 will be the scar tissue. Recent INICT question. The question is asked about the day 1 to 3. What is the pattern of you are going to see in the light microscopy? Okay, so these are the important points and that you have to cover, and examples also very much given, guys. So please don't forget and revise these topics. So those who are new to this channel, please do subscribe and share with your friends.